Healthcare innovation. How's your shoulder, Prof?
Oh,
Are you
very
good?
good, very good.
No,
Thank you.
no pins at all, eh?
No pins.
It's interesting. In this room, I bet you at least 10 to 15%. Somebody's had a shoulder problem in their life. Who's had a shoulder problem in the last 5 years? Put your hands up, please. Hey, extraordinary. That's a lot of people. There's future clients here.
Well, I'm going to tell you, my daughter, who,
Yeah.
when she was little, and she said, Dad, you do so many shoulders. She said, the only problem is people have two of them.
Think about that for a second.
I'm not being negative. I'm telling you.
Welcome. It's lovely to have you. How was your flight?
Thank you. Better than I deserve. It was
Do
great.
you love South Africa? Are they
Let me
giving
tell
you a
you,
warm South
I
African
will say
welcome?
before I start one thing about this.
Yeah.
I've been here 5 days.
Yes.
I'm Ethiopian by
Yes,
birth.
yes, okay.
I've been all over East and West Africa, never South.
Yeah.
This 5 days I've been here, and I honestly mean it from my heart, this 5 days I've been here, I get now, like him or not, I get the fertile grounds in which Elon Musk, I understand this man a lot better. There's a lot of innovation, the fertile ground of innovation from here. So
Yeah.
I'm very, as an American, I'm very, very impressed by it. So
Yeah.
thank you.
Well, let me show you something. Ladies and gentlemen, please let's give Dr. Gobezie a warm South African welcome.
Well, thank you very much. Unben, thank you for having me. It's a real privilege. My name is Ruben, as you know, and I'm going to share with you a little bit of a story about our last 5 years dealing with MSK digital healthcare delivery, okay? And what I'm going to tell you is not really, even though I'm going to talk about MSK healthcare delivery, it's really a story about healthcare, right? And we're all on this journey together to figure out all the different ideas translating into how we deliver care to human beings, okay? So that being said, the ultimate dilemma we all know is this dilemma. It's demands versus resources, right? Translated into our language of functionality, it means access over the cost. Ron Whelan talked about that this morning, that great idea is how do we get that to the cost section? And therefore, I'm going to tell you my story starts with MSK for 2 reasons. Number one, I'm an MSK provider. I'm an orthopedic surgeon by trade, okay? But number two is, it happens to be the number one spend in healthcare. This is data from the Lancet Journal on U.S. healthcare system. We do a lot of things wrong. One of them is we spend too much money. But basically, the MSK is expensive, it's common, and it's chronic. It's expensive in that, 70% or so, 50% of Americans suffer from MSK pain. 77% of them, as you see here, have of the visits to a healthcare provider are injury visits in the MSK space. It's the number one chronic condition in the world. So that's true too, and it's $380 billion. In the United States, it's 5.9% of our GDP. Tech team, is there any chance, because my eyes are not that good, can we make that bigger so I can see it? Because otherwise I have to turn around. So maybe I need healthcare, ophthalmology, AI or something. But anyway, so despite all the apps, because there have been app companies in the MSK space since 2014, large companies since 2014 in the US, healthcare costs have increased every year. In fact, up to 50% increase from 2016 to today. So it's not moving the needle on cost or total cost, like Ron said this morning, the perspective of total cost of care. And I think that results from 3 things. Number one, it's the ineffective use of technology. The fact remains that most applications are not integrated into the clinical workflow of the providers or the practices, so that makes it difficult. Number two, there's a lack of clinical care pathways. One of the biggest issues that, in terms of cost, is standardization of healthcare delivery. Without standardization, you can't manage what you can't measure, you know that, and so you can't measure it, okay? And then the final one, which is a tackle for the next session, maybe next year or the year after, is steerage. People going to the right point of care at the right time. Johnny sprains his ankle in rugby practice, you don't take him to the hospital ER. It's the most expensive place to get care. You don't need that. So those are steerage issues. So in order to have success in any measure, okay, we have to align, which is one of the challenges of just the technology is cool, but how do you make the system where you align payers and providers? How do you get them on the same page? Because you're going to have to do that to solve the access and cost issue. We know that in the U.S. We're grappling with it ourselves, and we haven't figured it out. It's a journey, right, for all of us. And at the end of the day, technology is really about leveraging technology to in a new healthcare delivery model. You're going to need a new healthcare delivery model, which is going to require change management, okay? But at the end of the day, payers and providers must be aligned. So what is the healthcare delivery model we've evolved to in the US for MSK? It involves 3 arms. One, telehealth, virtual therapy, okay? Why? Because many people this morning have already brought up the issue of the human connection. Where's that intersection? Where's that balance between human connection and technology, okay? And number one. Number two is it allows each physio and biokineticist to see more people. The productivity of the individual can see. So in our world, they can carry 200 patients a week. It's a lot more than you can do in an office. RPM, remote patient monitoring, again, mentioned earlier today, it is the concept that you are monitoring patients throughout their care plan, and you're using technology to do so. Okay, that's the second arm. And it allows them to engage, the patient to engage directly, but it also allows us to measure their compliance, which is an important part of the risk for all of us. Number 3 is web and mobile access, okay? So in other words, 92% of South Africans have a smartphone. I know that now. We just crossed 6 billion smartphones in the world. It's ridiculous, but it's crazy, but it's true. It's good, right? And it allows access. Any technology, and there's a couple of features that any technology in the MSK space, and remember, this is a story about healthcare, so it's the healthcare space. Any technology is going to have to have features. It just can't be an app. It has to have the features that work in our workflow. Yes, security information, telehealth, EMR integration, electronic medical record integration, monitoring technology, billing technology, et cetera. The point is, you got to have those components in a tech for it to work in the workflow of a provider, okay? And the other thing we've learned, the 2 features, A, you got to have the tech right in the workflow, but B, for practices, we tried giving them the SaaS model, the technology as a service. You give the doc, good luck. Let me know how that works out for you. It doesn't work, okay? We tried that. Any solution that comes must have at some level technology, the actual service provision of the human element, the workers, the workforce, and the management of the workforce all integrated in a solution. Without that, you cannot successfully have a engagement rate that's meaningful. You can have the tech, you won't have the engagement. So if you want success, you got to do that. So change management is a part of all of this. This has been brought up this morning already. How do we change not just the technology, but the people behavior behind it on both the provider and the patient side? And here's the APTA. It's the largest physical therapy association in the world. They are our toughest customers. They will be here too. Our toughest customers are getting the physio and the kineticist, in other words, the humans who are deploying the care, to actually embrace the technology. When I started this in 2018, it was the most difficult discussion. Now, and there's a story to that, I don't have time to get into that now, maybe in the discussion, but now the APTA has taken the position that yes, digital technology is meaningful. The pros and cons of digital technology are also meaningful, that there is a definite evidence-based material on the increase in access with apps and technology. There is better adherence to the care plans. The literature shows very poor adherence to the care plans for home exercises, okay? And that scheduling, flexibility, workforce empowerment are all part of this, and that they back it. Their official position is, yeah, you know what? We were essentially wrong. We back it now. This is the way of the future. This is something that we buy into. So their summary, virtual musculoskeletal solutions guided by therapists can reduce overall health care costs, ease administrative burdens, close the access gap, improve clinical outcomes. And the reality is physiotherapy, and I've learned some things about South African physiotherapy, the marketplace. It's an interesting place. It is under-leveraged, underutilized, and undervalued, just like teachers in our workforce, okay? They are the key part of, there's lots of data, and reduction of costs by preventative before surgery. A knife is covered, physio is not, dumb. You can't get it, human behavior will go where you motivate it, okay? So here we go, here's the tech, here's what it looks like, here's an example of one, okay? They can have a care pathway, the patients can use their phone, they can look through the different kinds of exercises that they're assigned by the physio. If they have questions, they can look at it, they can put a pain score in, and they put the phone down. And now, each day they're given the exercise to do. It's driven by, and Prof. Shafi, I'll be very careful about the use of AI in my language here, but it's driven by AI-based technology. It knows the difference between right and left. It knows the difference between active and passive. These are all technical terms in the MSK space. But the point is, there's a person in the back end saying, keep going. The green is where the patient is told by the physio to go to, the goal range. If they go above or below, the patient sees it's red. It's not right. They're told immediately, yes, you did green, you did X reps correctly, Y reps not correctly. There's integration now for TheraBands, use of strengthening, so it's not just move your arm, it's strengthening your core, strengthen your shoulder. There's all sorts of capabilities, just like in the office. It's not that different, and the whole point of this is to show in the MSK space how similar you can make it. You can't make it, somebody said touch the patient, you can't actually touch them, but you can pretty much replicate the function of touching. Not all the way, but some of the way, you know what I mean? So we find about 20% of patients can't or not appropriate for total virtual care, but the majority, 50%, can do complete virtual care. So you can do patients with all sorts of exercises. You can do time-based, for example, not just what the range of motion is, but like how long, do this for 10 seconds, do this 10 times, etc. You're getting stuff that you could never get until today, which is functional data, not just patient-reported outcomes, which are fraught with terrible problems in itself. This is changing the way we get data from humans. We now know functional data. If they have a problem, they can say, hey, I have a problem, and off you go. You know, and here's the other key. People can communicate, and these are all points we've touched on this morning with various talks so far. From the provider side, I want to talk about increased productivity for the workforce. The provider sees this on the right-hand side. There are text messages. The group of providers taking care of a practice can answer the text messages, or they can jump into the video calls. The video calls, in a physical therapy visit in the office, you do two things. One is you review the exercises with a patient. How do you do that virtually? This is not a Zoom call as you see here. I'll show you in a second. The second thing is you train a patient on how we're going to change your care pathway, your plan of care. So here's an example where there's a library of exercises you can review with the patient. The physio can actually walk through and explain to them, I want your elbow to cross your chest. I want to have buy-in from the patient in real time with a human that says, this is the goal of that exercise. That's why I'm going to add it to you. I'm not just going to send you a video. I'm going to explain it to you. You know what I'm saying? Any technology that you're going to try to replicate has to have the element of human contact for it to be effective. We are social beings. I'm sorry, we are. And I'm not sorry. It's the truth. So maybe sometimes I'm sorry, but most of the time I'm not. But you can review the care plan with the patient as well. You can adjust it. So when they go to the phone the next day to do their exercise, they understand what happened here. They don't just go on it. They can see what's happening, okay? And I fast-forwarded my trigger finger here. I fast-forwarded, you can also attach the patient education. It's swollen. Here's directions for ice, and so on and so forth. Data. Now, this is a touchy subject on every level. We've already talked about cybersecurity, but there's also touchy on another part. Who holds the data, right, and how that works. I'm not going to get into that. I'm going to start with this, though. What does the literature say about equivalency or superiority of virtual programs versus brick and mortar, you know, and a lot of data. I mean, I'm going to give you a sliver. The point is, it's comparable, or, as I show you here, superior. And these are mostly dealing with knee pain and, of course, back pain, the number one nemesis for most of us, back pain. So depending on which study you look at, there are very few that say it's inferior. Second point of data, and I'm going to give you a little taste of what we can do in understanding human behavior linked to outcomes, which is this. First question, this is a study that was presented several years ago from our data set looking at can elderly patients deploy a virtual program? And the answer is yes. In fact, turns out that after COVID, grandma can look up the menu from a QR code pretty darn easily, okay? So we've learned that that's not that hard, and they have more time. So it turns out that they can actually do the sessions 80% versus 50%. When people get back to work, it means they average one session a day. They've got stuff to do, you know, whereas the others don't. But let's get more interesting in the data. How about behavior? Is somebody's attitude towards therapy impact their outcome? So here's a study where we looked at and we asked the question, if we assign a patient an exercise program twice a day, in the morning and in the PM, and we asked the question, those humans who actually do the exercise program as assigned, daytime, nighttime, not oh my gosh, I'm having a telehealth appointment tomorrow, I better get my things done and bang out 2 in a row, okay? We started to see that trend. In other words, is the attitude that the patient has towards their therapy, that's what we're really measuring. Are they serious? Do they do it when they say they're going to do it? Do they schedule their time? Does it impact their functional outcome? The answer is yes, it does. So patients who take their attitude seriously, you can start to understand human behavior and attitudes and the impact ultimately on the outcome. This is one relevant for South Africa, and it's even, believe it or not, I'm sure you do, but if you don't, trust me, it's relevant in the US. We are moving to risk-based contracting, providers, where we get paid more if our outcomes are better, we get paid less if they're not. And hence the battle between who owns the data and who's going to determine what good and bad is. Okay, that's what really is. But here's a study looking at a single surgeon. So we didn't want to say, hey, you know, that surgeon's a hack, that guy's pretty good. That's why the outcomes are different. We use single surgeon series, standardized protocol, so care pathway standardized, and 5 months. We chose rotator cuff surgery because it's one of the most demanding surgeries for the patient. And we put them on bands. So the bands exercises you see here, to the right is a stronger band, means you're getting further along in your rehab. To the light color is a lesser band. And we looked at 44106, and I'm going to butcher this. Stellenbosch, I love that place. That place is amazing. Stellenbosch would be the affluent area versus the inner city. Okay, 44122. In our country, it's zip codes. So in our zip code, the rich area versus the poor area. And we asked, I hate to say it that way, but that's what it is. And we asked the question, do outcomes differ? In other words, if I have a practice, you know, I know Dr. Unbunny, I know you are a passionate man, and you care for everybody, and even those who don't have, right? I know that. But if you do that, do you want to get penalized because your outcomes are maybe different? Because maybe the nutritional state is different, maybe the resources are different, all these things. And the answer is, in the Stellenbosch area, and this is no knock on Stellenbosch, I got to tell you, I love that place, that's amazing. But in the Stellenbosch area, results were better, more strength, better functional outcomes. It doesn't mean that they weren't happy. The functional results were different, okay? And so there's a different outcome in the LS affluent area. By the way, they were actually quite happy. In terms of patient-reported outcomes, which is interesting, very similar. In terms of functional outcomes, which is ultimately what gets you back to work and so on and so forth, and that thing, different. So lots of engagement. If you have the human element, you get lots of engagement. You get people in the system for 90 minutes a week. That's our average over about, you know, we have about 200,000 patients a day on this system now. 48 minutes of interaction with the biokineticists a month, 40 minutes a month of live interaction with the patient. So this is something you can scale over time. And the cost, I've queried about the South African cost structure, and I realized a month of physio on a virtual program, which gives you 7 days a week of access and texting to the physio or biokineticists, et cetera, is about 1/4 the price of in brick and mortar care. So if you're going to move towards a universal, I've learned not to use NHI. Okay, well, universal healthcare. Okay, I'm not in the country, so I don't have a dog in this hunt. I'm just telling you, universal healthcare, you know, is going to be definitely cheaper. Okay, so it can be done. Okay, I believe it can be done, but it will require a change management. It will require a change in healthcare delivery. Thank you.
You know, it's an amazing technology. I downloaded the app. Is it Genie Health SA, right?
Yes.
Okay.
Yes.
So how does one join now? Because it's asking me for a username and password, but there's nowhere to register.
Yes, that's a great question. So the answer is, when you go on to and download it, typically we give a QR code, right? So Discovery, for example, has access for their patients on it, but basically it's gonna generate a referral on the back end, and very soon we're committed to providers and payers alignment, because in the U.S. that's the only way it works. So now it'll generate a referral to our South Africa team. They'll reach out to you.
Well, I think this is brilliant. You know why? Because I'm speaking for myself here, right? Because whenever I go to the physio, you know, if I've got a shoulder problem or a hamstring or whatever the case.
The Padel.
Do you get a lot of those injuries, eh? Okay.
Oh yeah, we do.
So here's the thing. I mean, the physio will tell you, do this exercise. You know, you're in the physio's room and you say, do this, this, that. But do you ever do that when you go home? You know, because you don't have the visual thing. And I forget that stuff. And they're saying, oh, you must reach out, make sure your leg is back like this. And you never remember this stuff, which is why this app is so brilliant. And then what lands up happening, we all go to Instagram to see the exercises now done. You see, so you can agree with me there. So this is a fantastic way.
Thank you, yeah.
How many subscribers do you guys have out of interest?
We average a little over 200,000 a day.
Yeah. 200,000 a day
Yes, sir.
that go on and do a physio session.
Active patients, yes, sir.
That's
and,
amazing.
And there's a story behind that. When we maybe later on we get into the economics of it. It's recently that it's really exploded because of the change from the payer side, and in recognizing the change on the cost side. So 2 years ago, okay, we averaged 850 patients a month. We're 200,000 a day now,
Yeah.
and that's all about the payer-provider relationship. You cannot do this, in my opinion, in our experience. I'm not going to tell you my opinion. Our experience in the U.S. so far is you cannot change digital healthcare delivery without an alignment between the payer and the provider.
Yeah.
If you just go to the payer, it won't work. Patients, the
Yeah.
uptick is 1%.
Yeah.
Adoption rate 2%. If you go to the provider without having a payer, it becomes difficult too. So there has to be an alignment there.
Okay. And do you work together with surgeons post-operative recovery,
biggest
right?
market.
That's
Our
the biggest
biggest
market.
market,
So that
Back
the
pain and
surgeon
that.
will say, okay, go and download this app and do those exercises afterwards.
Exactly.
Fantastic.
Thank you, sir.
Right, so Stellenbosch is the place to be.
Stellenbosch, I've only been to
And-
2 places, but that's the place is
And
pretty
you
good.
pronounced it correctly, so that's fantastic.
Thank you, sir.
Thank you very
I'm
much.
working on my Afrikaans next. Give me time.
Good man.